performance excellence, I'm going to take you through a story, and I want to take example of the institution I work in, Max Healthcare, to showcase what, according to us, performance excellence could mean. To reach a level of excellence in performance, I think each individual stakeholder in healthcare has to perform excellently. So how is the environment made facultative or creative so that we can allow all people, all employees, all retailers, clinicians, the junior most employees working together in an environment which can get the best out of them, is what we are trying to say. So these are the heads I'll try to talk on and try to cover my talk in the next 10 to 12 minutes, which have been allotted. Coming to the vision of the organization, if you see the key words which are present in this: best in class healthcare, total service focus, institution that is committed to highest standards of medical and service excellence, patient care, scientific knowledge, research, and medical education. Now, in my next 10 minutes of discussion, will concentrate on these key points, because these key points, if delivered to the core of what they actually mean, I think we will get the performance excellence. Now, 5C framework is the basic framework which we work under, and so 5 C's are care, commitment, cohesion, clinical excellence, and compliance. I think these are core to the performance and execution and working in any healthcare environment. When we talk about care, it's a culture of patient first. Commitment is that whatever plans, whatever discussions, whatever targets, whatever plans have been made are to be achieved, and this is even more important in a healthcare environment. And when I'm talking about targets, I'll talk about what targets mean, and please do not understand targets as financial targets. Targets are deliverables which each stakeholder in the organization is supposed to be delivering, and take ownership of that. Cohesion. There's nothing which an individual can do, and more so in this complex environment, and that's where the concept of team and getting individual egos out is very, very important. Clinical excellence, I think that is why we are all here for, and why we work in a healthcare environment, to give the best we can for our patients. And compliance, I think more so in present world, but anyway it is required that we comply with all the regulatory compliances which are there in the present environment. So this is a brief snapshot of how we strive to achieve our vision and reach a level of performance where we can think of reaching the excellence. Of course, we've spoken about clinical excellence. I'll talk more about this. But service excellence, in previous talks, a lot has been spoken about collecting data and need of getting it validated. Well, I very strongly feel that if we are capturing our data, and if we are capturing our data in a rightful manner, there is no need for getting it validated. Of course, you need to measure your standards against some standard benchmarks. You need to measure your data against some standard benchmarks. When it comes to service excellence, it is important to get it validated. And during my discussion, those differences will emerge. We actually went from a process where we did our internal service excellence assessment to now getting it done by a third party called IMRB, and which gives us how our patients feel about us. A very, very, very strong focus on medical technology and information technology. And I think that's where the present healthcare organizations which adopt technology early would clearly take a lead. A very, very proactive stakeholder engagement, and when I talk about stakeholders, it means all the internal stakeholders also, so the doctors, nurses, employees, and of course, your financial stakeholders, if any. Aligned and guided execution, we just spoke about the 5C model, and the performance management. I have a few slides as to how we set the goals and how we encourage and support our colleagues and employees to achieve those goals. So people, process, and technology. This is essentially what my previous slide showed, is the core, is the basis for a successful implementation of processes. And what you see on the other side is the IMRB score. Essentially what it does is gives us feedback of all 360-degree feedback of patients indoor in the outpatient services from poor to excellent. So who are the patients who will recommend others to come to us and those who will not. And the idea is to get the T2 minus B2, the top 2 minus the bottom 2 score to as best as we can. And it's a journey, and a lot of steps need to be done to reach that. So coming to the clinical excellence part, which I think is the core, and it revolves around the various activities you do around patient safety. A lot has been spoken in the 2 days conference. Of the points you see on both sides, there are a few things which I'll talk about in detail in subsequent slides. Patient safety goals, of course, all of us have been implementing that. There have been challenges in that, and there have been success stories. We, in our organization, are now in a stage where we have been implementing these goals for last 3-4 consecutive years, conducting simultaneous activities in all the hospitals. The core is to assess the effectiveness of these safety goals on the ground, and for that we conduct 2 patient safety audits in each unit so as to get a feedback. And this is, we get a huge degree of cooperation from all our employee base. Now this is the tagline which we have recently adopted for our network hospitals, eager to get you home. What all activities can be done so that we can send our patients home, which revolves around a lot of activities which will encompass the clinical services and the service component to it. And a lot of things which have been discussed, the turnaround times, the discharges, the billing, etc., all actually feed into this thing. And we even tell our employees, you do your work fast and go back home in time. And these are some brand positioning and communications which goes towards that concept. EHR has been a very successful story for us. We launched that way back in 2011. Actually, prior to that also, we had a very robust hospital information system. But since 2011, increasing hospitals in our network are coming into complete end-to-end seamless EHR and trying to get as paperless as possible. It has been a tough journey, no doubt. There have been challenges. Now we are in a stage where we can make meaningful use of the extensive data which we have in our systems. And I'll showcase you a few slides how we are now using that data to actually feed that into patient safety, help our clinicians write papers, and even go to what we understand as predictive analytics, helping patients in healthcare. And of course, to have an end-to-end EHR, all these need to be integrated and speaking to each other. And way back in 2012, that was a year after implementation, we were at the HIMSS level 6, which is an international rating of adoption of EHR, with the highest level being level 7. Now to achieve this, there's a very strong governance model, and I would say a rather unique governance model which we have in place. So the accountability, the alignment, the focus is coming from the board, so it's a board driven. And we have 7 committees at the board level which basically are looking into the service and the quality excellence, so extreme focus even at the board level. Then we have a managerial vertical and a clinical vertical which actually speak to each other. And the leadership committee is the executive council, and at the unit level we have the management council. The interesting part is on the clinical end, which is a very unique governance model at a network level, which is called the Group Medical Advisory Committee. So which is constituted by 7-8 senior most clinicians with the CEO and MD, myself being there, and it is a more of a strategy forming unit. And then at each unit, we have a committee which is run by senior clinicians, with one person being represented as a medical advisor. So this is one committee where most of the issues which are related to clinicians are thrashed and openly discussed, assets discussed, any new clinical programs, any technology which is to be brought are discussed at the unit level. So this is one very, very important forum for us, and something which is giving us strength of connect with the clinicians, directly contributing to administrative part. So this I'll skip. Now, the other important part is the performance management cycle. So this is an annual appraisal cycle which links an individual's goal and performance for that year to the organization's goal. And this is a very robust, very rigorous process. This year's process is about to complete by 3rd week of April. So it starts from setting the goal at the organization level, then percolating it down to the department level and an individual level, followed by an appraisal which is done for all the employees and retainers in the organization in a very, very objective manner. And next half a minute, I'll actually show you what we mean. So everybody in the organization is supposed to set a goal for himself or herself. A new employee who joins, within 30 days of joining, sets a goal. And for a lot of cadres, we actually have preset goal sheet, which with minor fine-tuning can be made. So everybody sets a KRAs, key result areas, and competencies. So this is what you do, what is deliver, and what you are expected to demonstrate in the organization. So as I said, the goals from the individual to the department to the organization all are linked and in sync with each other. So how we conduct this, I'll show you an objective way of doing it. But now, just last part of my presentation, coming to the results, how has it impacted? We've been talking about data collation, so there's an extremely robust process by which we collate data, and these slides are just to show you a dramatic representation of how these have affected or resulted in process improvement or performance improvement. So the IMRB score, that's the service excellence third-party scores, have improved from 42% to 63%. Now mind you, this is T2 minus the P2, the top two minus the bottom two. 21% increment over 2 years, the number of complaints per 1,000 reduction by 30%. Now, for the last 2 years consecutively, we have been undertaking large number of quality improvement processes, and this is an example of a number of processes we undertook last year, 2016-17, 226 quality improvement projects, which came under these 4-5 categories. 80 of these were patient experience, so the goal point was the T2 minus B2 scores improving. No linkage to revenues in that. The next is clearly a business improvement process, revenue improvement process. 44 projects were linked to that, and we accrued a benefit of 40 crores by these projects. Cost reduction without impacting the patient care. Simple projects, 34 of them resulted in a return savings of 15 crores to us. 34, 35 projects which are directly linked to patient safety. And the goal point, improvement in the patient safety goals as assessed by the patient safety culture survey. And few directed at reducing the the employees' attrition. So this is the result of last year's projects which were closed, 190 out of 226 projects which got closed, and how we sort of benefited on those. In terms of clinical excellence, we launched this interesting project called Chasing Zero. So how close can we get to zero in anything which is preventable? So whether that's a mortality, whether that's a patient fall, whether that's a needle stick injury, whether that's hospital-acquired infections, how close can we get to zero? And these are just showcasing some values and statistics of how in 2 years the figures have moved down significantly. Now, we claim and clearly tell you that the infections which we are reporting are all system generated. There is second level manual interface where we actually vet the data which is system generated, and the system generated data will pick up false, it will over report and never under report. So we can confidently say that there is not a single HAI which is being missed or not reported through the system. Unplanned readmission, the BCMA, the barcode medical administration, which is an extremely vital tool to prevent medication errors. So you cross-check with the barcoding, which is on the wrist of the patient band, and on the medication which is being given to the patient. And each time before a nurse gives that medicine to the patient, oral or injectable, she has to scan the barcode on both the sides, and it has to show a green light before the nurse gives the medication. Compliance to documentation, the turnaround time, how long does it take for us to give first dose medication to the patient after he's admitted into the hospital. So these red lines which you see are targets, benchmarks which we set for us, and we keep going stricter and stricter with these benchmarks. So we have put extreme focus on academics and the publications by our colleagues, and we have committees and a lot of support which we give our clinicians to help us, help them write these journals. But this has been an interesting story for us, VTE prevention. I don't have too much of time, so I won't take this, but it's a journey where in next few months, I can very confidently say that we are going to declare the network hospitals of PACS Healthcare as VTE-free hospitals. I can actually do that right now standing here for 3 of our hospitals which are consecutively running at 100% compliance to our VTE prophylaxis for last 3 to 4 months. And this is a journey where we want to go very, very fast. And again, this has happened completely by virtue of clinicians buy-in and our electronic health reports supporting the clinicians in terms of generating those alerts. I'll skip DDD and DRI, drug resistance index, we are capturing the ACLS category. No, this is a very robust mortality audit process which we have in our system. 100% mortalities in our system are audited, and we categorize into deaths which could have been prevented, and the whole idea of this exercise is non-punitive, it is blinded, nobody knows whose patients were those, and the whole idea is to get learning points out of those mortalities and create policies and processes so that we won't get repetition of those errors which might have led to those complications. This is what I was talking about. This is a type of example of a balanced scorecard which we have now implemented for each clinician above a consultant rank for all departments. Presently, this is operational for our Saket complex and has been launched pan-max. So, and this is specific for each department and is captured on a monthly basis and sent to the head of department. And this, other than having the business matrix to it, it has a quality matrix, it has research matrix, and teaching and academics matrix to it. And your personal number of hours of CME which you have attended. And a lot of data from this actually feeds onto this appraisal sheet. And it is based on basis of this data that the head of department appraises the consultant at least once in a year. We have put Q3 as a time when once a year appraisal will happen, and most of the data points are actually captured by the previous scorecard. So it's a highly objective process of appraisal which I had mentioned in our performance management system. These are some nursing quality parameters which we capture. I won't concentrate on them. So we have brought down attrition significantly in a lot of cadres, nursing, doctors, and very recently we have had a successful JCI accreditation for Saket complex, and now a lot of other units are very excited to go into that journey. So I think for us, quality is a journey. And I don't think that every year we have to just keep increasing upping our bars until we achieve zero. So I get into a lot of controversy when I use this word zero, and a lot of people tell me a zero can only be achieved in a healthcare which is dead and there are no patients in it. You know, I actually have figures to show contrary to that, where we have actually reached either 0 or 100, whichever is the target, in some of our hospitals, and you know, we soon shall be there in a lot of our hospitals. Thank you.